Okay, yeah, let's get started. So welcome to the summer series of our grand runs again. So for those who are not familiar with the summer series, it's designed for our first year neurology residents at the very beginning of their training. So it's a sort of a crash course that covers topics that they really need to know when they are on call on their own. But I think it's also a very useful refresher course for those who are not N1 anymore, but they wish they could have learned things the right way. So our first speaker today is Dr. John Miller. So he's director of the UW Regional Epilepsy Center based at Harborview. He's going to talk about diagnosis and the treatment of seizures in epilepsy. Dr. Miller.
Thank you. So we should explain that last week there was a notice going out that I was the second talk, and Kimmy and I decided to trade because we thought it's better to talk about introduce the topic of evaluation and treatment of epilepsy before we talk about status epilepticus, which is really a special topic. Good. Okay. So these are the objectives, and really there's two main things I want to get across. So there's a lot of things I want to get across, but there's two main things I would hope that we could retain. One is some basic idea of how to classify seizures and epilepsy. And this is a complex topic. There's a handout outside on this topic to expand on this topic because it really isn't straightforward. It's hard to just describe it in words. And then there's a linked topic, which is when to start anti-epileptic medication and how to start it. And it's linked to the question of classification because the first step in deciding which drug to use is understanding which type of seizures and epilepsy you're treating. And of course, this is just an introduction. The real way to learn how to do this is to do it in the clinic, in practice. And the best place to do that is through rotations at the Children's Hospital and at Harborview, where we have unbelievable number of epilepsy patients that we treat. So, what's a seizure? And there hasn't been much progress in this topic. This is a definition that comes from the middle of the 19th century from Ulix-Jackson. It's simply abnormal electrical discharge in the brain. There really isn't a good clinical definition of what a seizure is. That's because the behavioral effects of seizures are so varied and so diverse that it's really impossible to make a definition that really does justice to that. So we rely on the pathophysiological definition. Epilepsy, on the other hand, is I was told they're supposed to point with a mouse. Oh, here it is. Okay. Epilepsy, on the other hand, is something that's very straightforward, but people get confused about. Epilepsy just means you have seizures. If you have chronic recurrent spontaneous seizures, you have epilepsy. A seizure disorder is just another name for epilepsy. So seizures are far more common than people realize. The lifetime risk of having one or more seizures is actually almost 10% by the time you reach age 80. So 1 out of 10 people will experience a seizure at some time. However, only about 3% of the population will ever have epilepsy, chronic recurrent seizures. So that tells you right away that a lot of the seizures that people experience are either isolated single events, not epilepsy, or acute symptomatic seizures from illnesses of different sorts. Beyond this, only 1% of the population is under active treatment for epilepsy at any given time. Age dependency I'll talk about in the next slide. Cost of epilepsy. These figures here are actually 20 years old, so they're really not up to date. But I really put them here just to make the point that the main cost of epilepsy is not medical care, even though it's pretty expensive to care for these patients, but it's the disability from epilepsy, the indirect costs. So this slide just illustrates the age-specific incidence of epilepsy. So epilepsy is most likely to begin either early in life, especially in infancy and young children, but then there's another peak in the geriatric population. And the time when it's least likely to occur is people 30, 40, 50 years of age. oops. And the reason for this is that for the peak in later life is primarily because of seizures that are occurring as a remote effect of stroke. So now I want to go into the classification. The classification schemes for seizures are very confusing, and the reason is that about every 20 years they have another committee, and they come up with a whole other set of terminology, but the old words never go away. And so, for example, you talk to patients, they say, what kind of seizures do you have? You say petit mal and grand mal. Well, where do those terms come from? It actually comes from an article in the French literature in 1829, before people even knew what a seizure was. And so it's really quite confusing. And this is based on what we usually use, which is the 1981 classification. There's a subsequent 2010 classification, but that makes things more confusing, so I'm not even going to talk about that. But the reason why classification of seizures is important is it has a big implication for how you work up the patients and the treatment you give them. But as I said, this is confusing. It's hard to do this just with a diagram or a few words. So there's a handout just on this topic that goes in detail through the different seizure types, and then actually there's links to YouTube videos. So the issue of patient confidentiality is easy now because people post their seizures on YouTube. And so you can click on the links and see examples of these typical seizure types. But the most important distinction is between focal seizures, this row here, which are seizures that begin at a specific place in the brain, usually in the cerebral cortex or the limbic system, and seizures that are generalized from onset, which are seizures that begin either diffusely over the cerebral cortex or at least bilaterally and synchronously over the cerebral cortex. And the reason why this distinction is so important is, first of all, is a workup, because the majority of patients with focal seizures are felt to be acquired. And not all of them, but the majority of them are at least assumed to be acquired and not genetic, although there may be genetic predispositions that we don't fully understand. Generalized from onset seizures, at least in adults, are presumed to be genetic in etiology. So you can understand that neuroimaging is far more important for people with focal seizures. The other thing is medication choices, and we're going to talk later on about how seizure type determines the choice of medication to try. But the traditional way of thinking about this with the old drugs that we used to use 20 or 30 years ago, what were those? They were phenytoin, carbamazepine, valproate. Well, it turns out that phenytoin and carbamazepine were in those days were the drugs of choice for focal seizures, and valproate was the drug of choice for generalized seizures. And it was discovered years ago that phenytoin and carbamazepine sometimes makes generalized seizures worse. So knowing if somebody has focal or generalized seizures helps to get on the right foot with choosing medications. These other terms in the rows have to do with what the patient does during the seizure. So if the patient is alert and can respond normally, and it's a focal seizure, it's called a simple partial seizure. If their consciousness is impaired, which means they're not able to respond normally, it's called a complex partial seizure. And with generalized seizures, there are myoclonic or jerk seizures, which often have no detectable loss of consciousness, but sometimes they may. And there are absence seizures, which are generalized seizures where people lose awareness momentarily or for brief periods of time. And then both focal and generalized seizures may go on to convulsion or a generalized tonic-clonic seizure. So this is sort of a simplified version of seizure classifications. Most used for adults. There's all kinds of special pediatric syndrome seizures that don't quite fit into this scheme, but this gives you a basic overview of most of what you'll be dealing with. So this is sort of Rosetta Stone of some of these old terms. So you hear these terms, you read about it even in current medical textbooks, and certainly other physicians and patients use these terms. A focal motor seizure or a Jacksonian seizure is simply a type of motor simple partial seizure. People often say that psychomotor or temporal lobe seizures is synonymous with complex partial seizures, but in fact there are temporal lobe seizures where people retain awareness, and so they're simple partial. They may be simple or complex partial or secondarily generalized. And also, there are many complex partial seizures that come from other parts of the brain other than the temporal lobes.
Did you say simple partial with? I mean, you have to qualify it, don't you? Because it's not sensory, it's not motor. So what do you call it? And then it becomes cumbersome.
Say that again?
If you have a simple partial temporal lobe seizure,
Right.
what do you say? Simple partial
Seizure.
That's it? Because that doesn't really tell you much about what's...
Well, you know, there are other classifications. There's subclassification of seizures based on what the symptoms are. You can have subjective symptoms, you can have autonomic symptoms, you can have unusual feelings such as deja vu, you can have involuntary movements, you can have somatosensory symptoms. It really depends on what part of the brain is involved.
But it becomes cumbersome in writing it down.
Well, I mean,
The whole thing.
using the classification system doesn't necessarily tell you everything about a seizure. It basically puts it in a cubbyhole. Say this is a simple partial seizure, and then you need to use a description to describe what that particular person's seizures are like. And seizures are quite diverse because it is diverse as a function of the cerebral cortex. It depends on where they're coming from.
Okay, John, I'll be quiet.
Okay. You've heard this talk too many times. Okay, and then the thing I want to get across is petit mal. Somewhere along the line, somebody decided that the old term petit mal is equivalent to an absence seizure. Why they determined that, I don't know. But patients never got the word. So when patients tell you that they have petit mal seizures, almost always they're referring to complex partial seizures. That's part of the confusion about these different schemes. Okay, so enough for classifying seizures. So seizures are events. So this classification system is a way to take different diverse events and put them in cubby holes and give them names. Epilepsy is a condition. So epilepsy is a syndrome where it's defined by not just the kind of seizures that you have, but the causes of the seizures and the natural history of the condition and so forth. But there are two main ways to classify epilepsies. The first is by anatomy. So if somebody has seizures that are generalized from onset, they have generalized epilepsy. That's pretty straightforward. If somebody has seizures that begin focally, the old term is localization-related epilepsy. The new term is much better, which is focal epilepsy. It just starts focally. They have seizures that start focally in the brain. Then you can also classify them by etiology, by cause. And so if you have a patient who has a brain tumor and adult epilepsy as a consequence of his brain tumor, that's a form of symptomatic or secondary epilepsy due to the brain tumor. Then people who have seizures that are presumed to have a genetic cause, where this MRI is negative, there's no lesion causing it, but based on the whole description of their syndrome, it's consistent with a genetic syndrome. That's usually called idiopathic or primary epilepsy. And then they threw in this other term called cryptogenic. And cryptogenic means that there's a cause, you just don't know what it is. And so it's easy to get cryptogenic and idiopathic mixed up, but idiopathic means a presumed genetic cause, and cryptogenic means it's presumed to be acquired. You just can't define or pin down what the cause actually is.
But many cryptogenic causes are actually genetic, because and that's been shown by numerous studies.
Right, and the genetics of, this is a talk of the genetics of epilepsy, but also many epilepsy we commonly think of acquired is probably genetic predisposition. And so if you have two people who have head trauma, one may develop epilepsy, one may not have. There may be genetic factors to determine that as well. So next is what kind of seizures are most common? Well, when I was a resident in internal medicine, which was a few years ago, I used to think epilepsy was always convulsions because that's what you saw in the emergency room, and the most common cause was alcohol withdrawal. But in reality, if you take a whole population of patients, and this was done in Olmsted County, Minnesota, the most common type of seizures are complex partial seizures. Then the cause of epilepsy. The cause of epilepsy, this is somewhat old work. This is really data from the 70s and 80s, and much of it is before MRI, but it's still relevant today. The cause of epilepsy depends on the age. So if you look at a younger population, the typical causes are different from geriatric population. So looking at younger patients, the most common cause is the black stuff here, which is, don't know, idiopathic or cryptogenic. And there's a tendency for people to think of patients often think of trauma as a likely cause of their epilepsy, but really trauma in this chart is only 5.5%. So trauma is not all that common a cause of epilepsy unless you're working at Harborview, in which case it's a little more common. And then brain tumors, you always worry about brain tumors, but brain tumors are not, overall, aren't that common a cause of epilepsy. Important cause, but not, okay. And then that was the younger population. The geriatric population, it's a little bit different, but still the most common etiology is cryptogenic or idiopathic. But the big difference is this big red thing, which is vascular. And most of these patients are patients who suffered a stroke, and as a remote consequence of that stroke, the scar in the brain turns into a seizure focus and develop epilepsy secondary to the stroke. And then occasionally you actually see epilepsy develop in people with conditions like Alzheimer's disease and MS, although it's a small percentage of people with those conditions. But still, trauma is not that high, and brain tumors aren't that high, even in geriatric patients. So that's the basic definitions, classifications, and now I'd like to move on to the bedside. And so what do you do when you're in the emergency room or in the clinic? How do you actually diagnose this? And the wonderful thing about neurology as compared to other fields of medicine is that most of what your diagnosis is based on either the history or examination. And in epilepsy, it's a history. History is key. You make the diagnosis by talking to the patient and talking to the family. But it's a special kind of history. What you want to get is a spell history. So you want to get the patient to tell a story. You want to tell them them to tell you the story of their spells. So what do you pick one that they remember well, the first one or the last one, or one that they just remember well, and ask them, what were you doing when this happened? Some will tell you they're sleeping, some will be doing a certain activity. And they said, what was the first thing you felt? Then what did you feel? Then what happened next? What happened next? What happened next? And how did you feel when it was over? That's the kind of process you go through in getting the history. But the problem with seizures is that a lot of times patients have loss of awareness and they may have amnesia for important chunks of the event. So you talk to the patient, you may not get the whole story. You may not in fact, there are patients who have seizures that don't even know that they've had seizures. They only know that they happen if there are witnesses around them. So a key part of this whole process is talking to a witness, somebody who saw one of these events. Sometimes you don't have that, in the emergency room and so forth, but it's really important to try to dig up a witness and talk to them, even if you have to pick up the phone and call their spouse who's working, and get some kind of description about what other people see during these events. That's really often the key to making the diagnosis. And the differential of neurological spells is very straightforward. The big four things that we see are seizures, TIAs, migraine, and psychogenic events. But usually with a good history, you can distinguish easily between seizures, TIAs, and migraine. Seizures tend to be brief, they tend to be stereotyped. They often involve alteration of awareness, they often involve involuntary movement. And usually the history is, if you get a good, clear description, the history is fairly distinctive, and you can make the distinction from these other causes by that history. The biggest problem actually was psychogenic events, because people with episodes that have an emotional cause and not a medical cause may have events that can superficially mimic seizures very closely. So that's where you have to be very cautious. So here's an example. I've used this example endlessly. Dr. Swanson has heard this at least 5 times. This is a case that's over 20 years ago, but I think it's a good illustration of the process you go through when making the diagnosis of seizures. This is a patient I saw one Friday morning in clinic, and this was a fairly gruff, concrete kind of individual. my first patient of the day, and he came in the room, and I said, Mr. So-and-so, I'm Dr. Miller, how are you? What did you come to see me today? And he said, well, I have stomach pain. And I said, well, what do you mean stomach pain? He said, well, I get these cramps in my stomach that last for a minute or so. Anything else with that? No, that's all I get, just the stomach pain. I said, well, I'm a neurologist. Why are you coming to see me? He said, well, I had a grand mal seizure last year. I said, well, how did you get here today? Because he was from out of town. And he said, well, my sister drove me because my doctor told me I can't drive. So that's a key to something. And so I went out of the waiting room, and of course the sister had gone to have coffee, and it wasn't there. So I went back in the room, and I did the review of systems and the exam and all this other stuff we do. And then I went back out, and the sister was back, and I brought her in and said, tell me what happened. And she said, well, she never really knew what was going on until he was staying at her house because they were going to go travel into town for the visit. And he had one. And she said what happened is he got up out of his chair and went around the room, and he was grabbing things on the tables and moving them around. And she went up to him and tried to talk to him, and he just kind of looked right through her, didn't answer, didn't talk. And this went on for about a minute or so. And when it was over, she told her what had happened, and he didn't believe her because he had no memory of doing all this stuff. So it wasn't that this patient was hiding something from me. He didn't remember, and it's because of his seizure. But this is a clear history. This is a complex partial seizure. You don't need any other test or any other confirmation to know that this guy has complex partial seizures. But just to make it easy and more convincing, we sent him for an EEG, and he had a complex partial seizure with a right temporal electrographic discharge during the EEG. But we didn't need that to know what was going on. So this is what you do to make a diagnosis. Then you start doing tests, because this is modern medicine and we always do tests. But why do we do tests? Well, the one thing is to confirm the diagnosis. And so this gentleman, I was going to put him on medication. He's probably going to be on medication for long term. It helps to tell him, well, we have this EEG, look at these spikes here, we have proof that you have epilepsy, to convince him. So it's always nice to have confirmation if you can get it, but we don't need confirmation to that patient to really treat him. But the most important thing is to look for the cause. Why does a person have seizures? And the most important way to look for the cause is neuroimaging. And then we have unclear cases. I've mentioned patients with psychogenic episodes where they have events, so-called pseudo-seizures, that may mimic seizures. It's really helpful to have an EEG to really conclusively make the diagnosis. So those are the reasons why we get tests. So this is an EEG. You'll see patients with seizures. The first thing you'll do is pull out the requisition, order an EEG. Well, why do you do that? What's it for? Well, you're looking for, usually you're not expecting the patient to have a seizure during a routine EEG. I mean, you can if you're lucky, like the patient I talked about, but most of the time you don't get that. What you get are abnormal electrical discharges that are called intra-ictal epileptiform discharges. And if the EEG is correctly interpreted, these type of discharges are uncommon in people without neurological disease. And usually if you have a patient who comes in with episodes of some sort, it's good confirmation that they have seizures. That's the main thing. The second thing it tells you, it distinguishes between focal and generalized seizure problems, because, you can have the electrical discharges can be over a part of the brain, or they can be over the whole brain, or the whole cerebral cortex. That can help you distinguish when somebody has focal seizures or generalized seizures. So that's why we get EEGs. So if you have somebody come in clinic and they have episodes you think are probably seizures, they get an EEG, what's the yield of that? Well, this has been done multiple times, and if you get one good EEG on somebody in the situation, you'll see epileptic activity about 50% of the time. If you get multiple EEGs, which we usually don't do, but some places do, or they used to do in the old days, if you get 3 or 4 or 5 of these, you get up to 90% of patients with epileptiform abnormalities. So what that tells you is that abnormal EEG is very helpful. The normal EEG doesn't tell you very much, because it could be a sampling issue. Okay, and without going into detail, you can see spikes in people with CNS disease. So you can have patients, for example, with cerebral palsy, who may have spikes over the central parietal cortex, but not have actual seizures by history. So sometimes spikes are a marker of a damaged area of brain, but most of the time it's a marker for seizures. And if you're somebody who's neurologically normal and they have episodes of alteration of consciousness, for example, an epileptiform EEG is a very good confirmation that they have seizures. So this is a very easy, practical, and as medical tests go, inexpensive way to confirm that somebody has seizures and classify the seizures. And then there's a big expensive test called video EEG monitoring. This is I should change the title of this because nobody talks about closed circuit TV anymore. This is really video EEG monitoring. And this is what this involves is putting somebody in the hospital and recording their typical episodes. You know, you hook them up, you take them off their medication or whatever you need to do to make them have their attacks, and you record their actual attacks. And this may involve 2, 3, or more days in the hospital, so this is obviously a big deal to do. It's inconvenient for the patients, it's expensive. But why would we do this? Well, we do this for two main reasons. The first is if somebody's under treatment for seizures, not responding to treatment, going to the ER, getting lots of medical care, and you're not certain of the diagnosis, this could be really helpful, because if somebody has, for example, psychogenic episodes, not seizures, this can kind of break the case and tell you what's really going on and how to manage the patient appropriately. So one reason is suspicion of non-epileptic events, or so-called psychogenic episodes. The other reason is if somebody has epilepsy that doesn't respond to medication. And some of these people are candidates for neurosurgical treatment. And so we use the EEG monitoring to identify where the seizures are coming from to help determine if they're candidates for brain surgery to treat their uncontrolled epilepsy. So those are the main reasons why we do something like this. So here's my slide on non-epileptic events. People have come up with all kinds of names for this. I should change this slide too, because I think we've come up with the term psychogenic non-epileptic episodes. Some people call them non-epileptic seizures. The problem with that's actually traditional. The problem with that is it confuses patients, because these events really aren't seizures. They just look like seizures. So if you tell somebody they have psychogenic seizures, they just think, well, I have this other kind of seizure, you know. And really the message to give these patients is that they're events and episodes that mimic seizures but have an emotional cause and really are not epileptic seizures. So we usually call these psychogenic non-epileptic episodes, and I'm going to change the caption of this slide. And so a few points about this. This is all in your handout too. More common in women, but certainly can occur in men. There are some types of body movements that are suggestive of this, but psychogenic episodes are quite varied, and you can't just go only by the type of movement that the patient has. Most studies suggest that patients with non-epileptic episodes, you only find episodes of concurrent epilepsy in only less than 10% of patients, but there may be situations where that's higher. For example, we sometimes see these psychogenic events in people who've had successful epilepsy surgery and no longer have epileptic seizures. There are a subset of people who start having non-epileptic events. There's many causes. There's no one cause for this. It's a diverse psychiatric issues cause non-epileptic events, but one of the things that's common is a history of abuse in childhood. Prolactin levels can have been used. They reliably increase in convulsions, but only some complex partial seizures, and we tend not to use prolactin levels very much. We use them in the ER when we're not able to capture events any other way, but usually the best way to make this diagnosis is with EEG monitoring. The prognosis of this is often unfavorable, but it depends on a lot of factors in terms of the age of onset, how long it's been going on, and the underlying emotional causes. But you will all see this during your residency. Then neuroimaging. Neuroimaging is, we do neuroimaging on nearly all these patients. MRI has a higher yield than CT scan, so typically we want to do MRI and not CT as initial workup of these patients. However, in people who have first seizure, the yield is relatively low. It's probably in the range of 15% of patients have a cause for their seizures identified at MRI after a first seizure. But if you look at chronic epilepsy, people with chronic uncontrolled epilepsy, probably more than 50% of patients you can identify a structural cause. They have chronic focal epilepsy that's uncontrolled. And there's diverse causes. I have a few things here: trauma, focal cortical dysplasia. Here's somebody with a traumatic brain injury, but also mesotemporal sclerosis, or scarring of the hippocampus secondary to the epilepsy. And then here's a patient with a low-grade tumor, a ganglioma, that they had for 15 years before it was recognized causing their epilepsy. So MRI is a critical part of working up people with focal epilepsy, and everybody who has focal epilepsy should have at least one good quality MRI that you've seen during their workup. So treating seizures. So that's all the workup. Yeah.
So that 20 or 36 of 238, has that been looked at comparing 1.5T versus 3T MRIs?
That's actually an old paper.
That's
in Lancet. That's for about 10 years ago. So that's 1.5. And I'm sure the yield will be a bit higher with 3. It also depends on not just the resolution of the imaging, but who's reading the imaging and what they're looking for. As you know, that when we see images, we're much more prone to see mesotemporal sclerosis than when the MRIs just fly through the radiology department. So it's probably higher, and it depends on a lot of factors, including what you're looking for, who's looking at it, and the quality of the imaging.
Do you get imaging for generalized seizures as well? Or?
Well, that's a good question. And we argue about that, because the problem is that there are some patients who have very straightforward genetic epilepsy syndromes like juvenile myoclonic epilepsy.
Can you repeat the question?
What?
Can you repeat the question?
Okay, sorry. Okay, the question was, do we get MRI on people with generalized epilepsy? Thank you. And the answer is it's a difficult question that we argue about, because there are some people with straightforward genetic epilepsy syndromes like juvenile myoclonic epilepsy where the yield is quite low. But there's also a group of patients with generalized epilepsy where it looks like they have generalized epilepsy, but they actually have a focal lesion, like a frontal tumor or something of that sort. So we have a tendency to try to get MRI in all those patients, although we try a little less hard in people with a clear-cut genetic epilepsy syndrome. Rusty, any comments on that?
Well, yeah, because we see, obviously, in pediatrics, see more genetic epilepsy. So for absence, childhood absence, we don't, and some of the other early infantile generalized as well.
And of course, a lot of those patients we never see because they outgrow it. But yeah. So anyway, next step after workup is treatment. So how do you treat seizures? Well, the first thing is to counsel the patient about activities that are dangerous. And the first thing and the most difficult thing is counseling them not to drive a car. And the law and the policy in the state of Washington is they need to be 6 months without a seizure with alteration of awareness before they can drive a car legally. But there's other things that you have to worry about. Around here you have to worry about people going out rock climbing or skiing, which are very dangerous to do if you have a seizure. There's bathing, and one thing that's not recognized, that patients often don't realize, is that if you have a convulsive seizure in the bathtub, you'll drown. And so it's very important to mention that to patients, because you'd be surprised how many patients don't realize how dangerous that is, that they should take showers instead of baths. Then, of course, the mainstay of treatment is anti-epileptic medication. There's brain surgery, there's a vagal nerve stimulator, and there's a ketogenic diet. But for the most part, the majority of patients are treated either with anti-epileptic medications, plus or minus epilepsy surgery, with a small percentage being treated with a vagal nerve stimulator. So, when do we treat? So somebody comes in to see you and has a single seizure. Should we treat it? And the answer to that question depends on what is the chance it'll happen again. It'll have more seizures. Because I told you already, 9% of the population will have a seizure in their life, but only 3% will have epilepsy. Well, we have studies to show the answer to this question. For somebody with the overall risk of recurrence after a single seizure is about 40%, but if there's no cause found, normal MRI, a normal EEG, a generalized convulsive seizure, the risk of recurrence is only 24%. And this is in an adolescent population, this particular study. If they have an epileptiform EEG, the risk of recurrence is 48%. if it's symptomatic, that means the MRI shows the cause for their epilepsy. The risk of recurrence is 65%. So you can understand that you might not want to treat somebody with a single seizure with normal workup, but if somebody has an abnormal EEG or an abnormal MRI scan that shows the cause, you're likely to start treatment. Then what if they have a second seizure? Well, the risk automatically goes up to 60 to 80%. So typically you would treat somebody after a second seizure. So that's how you decide if to treat. But the next question is how to treat. And this used to be easy when I was a resident. We had like 2 or 3 drugs. We had 3 drugs that we really used, and so you said which one of these 3 drugs are we going to use. Now we have all these drugs, and what patients hate is they hate the feeling that their doctor's just throwing drugs at them randomly, you know, because they don't want to be a guinea pig. So that's what they tell you. So, or a guinea chicken, I guess. So that you have to have some principles and some system to picking drugs to put patients on to maximize the chance that you control their seizures and minimize the chance of adverse effects. It's short of this process of trial and error. So the principle, use a single drug, use generics if possible, because patients won't take their medication if they can't afford it. Slowly titrate the agent to reduce initiation-related side effects. Titrate to a moderate dose, see if it works. If it doesn't work, you try a higher dose. Watch out for allergic skin rashes, because that's one of the few ways you can really harm somebody with anti-epileptic medications. So that's the principle of starting it. So which drugs? Well, there's a menu of all this stuff, and this is all in your handout, so I don't think I have time to go through every one in exquisite detail, but just some basic ideas. Phenytoin used to be the drug of choice. Everybody with seizures in the U.S. got put on phenytoin. It's not so common anymore. Phenytoin is a pretty effective drug. Oops. It's a pretty effective drug. It's most used for focal epilepsy. It's not so effective for generalized epilepsy. Can cause nystagmus and ataxia. Can cause some cognitive side effects that patients don't like. The main problem with phenytoin is the difficult pharmacology of this drug, because small changes in the dose can make big changes in the level, and so toxic reactions to this medication and overdose are very commonplace. And you'll find that if you put people on phenytoin, all the doctors caring for the patient will be drawing levels and fooling with the medication, and the levels will be bouncing all over the place. So phenytoin is a very difficult drug to use, actually, and it's fallen less and less. It's used less and less. Carbamazepine or Tegretol is a very effective drug. It's commonly used. It has more predictable pharmacology than phenytoin, but it cannot be given intravenously. Valproate is also used commonly, but these days it's used more often for migraine and for bipolar disorder. But it's a very effective drug for generalized epilepsy. Issues with this are weight gain, which most people dislike. There's a risk of hepatic failure, primarily in small children, that you have to watch out for. And the problem in adults is that in women of childbearing age, the risk of major fetal malformations is approximately 20%. And it also has been shown to lower the IQ of the offspring. So it's really just key to avoid using this in women of childbearing age if at all possible.
John, what's the mechanism of the powerful tendency for weight gain with this drug?
Yeah, Alan's giving the answer, which is it probably affects both. It probably affects appetite. It probably affects metabolism, but somehow it affects the mechanism of regulation of body weight. But it's not really understood well, as far as I know, unless nobody in the room has an idea about that. Lamotrigine. We use lamotrigine a lot, and the reason we use lamotrigine a lot is that it's broad spectrum. It can be used for focal and generalized epilepsy, but we use it primarily because it produces less sedation and less depression, less negative effects on mood, and less reports of negative effects on concentration. The problem with this medication is a 3% risk of allergic rash, so it has to be started slowly. It has very complex drug interactions, particularly with Depakote. Topiramate is used a lot because it's broad spectrum, good for focal and generalized epilepsy. It's useful for treating migraine. It causes weight loss, which is, most people like the idea about that. Issues with it is a 1% risk of renal stones, and it's been shown to be associated with cleft palate in offspring of mothers taking it. Oxcarbazepine is related to carbamazepine Tegretol. It's a very effective drug. It causes somewhat less side effects in terms of dizziness, lower risk of rash. It's used a lot in the pediatric population. It's used less in the adult population because of issues with hyponatremia, which is not too much a problem in kids, but it's a huge problem in older adults. Zonisamide is a medication that is a broad spectrum, effective for focal generalized epilepsy. Causes weight loss, which people like. Can cause depression or confusion, but the main advantage of this medication is a long half-life, 63 hours. So it can be given once a day, and it's forgiving for non-compliant patients who miss doses. Levetiracetam requires some special mention because levetiracetam has become the drug of first choice for initiating patients on medication. And you walk around the hospital and the neurosurgeons use it, the neurology service uses it. Somebody comes with a seizure, they can put on levetiracetam. Why is that? Well, one, you can give it intravenously. Number two, it's a very safe medication. It does low risk of rash. There's low risk of medical complications, no significant drug interactions, so it's used a lot. What are the disadvantages of it? Well, the disadvantages are the side effects. When people are started on it quickly, it causes a lot of sedation. And I think there's an issue that if you look at the package insert, it says that the dose of this agent to use is 3,000 to 4,000 milligrams a day. And if you start somebody on that within a week or two, they'll be very, very sleepy and probably stop taking it. And in reality, lower doses like in the range of 500 to 1,000 milligrams a day work fine. There's no need to push up this drug aggressively in most patients, and you'll have less problems with sedation. But the main problem with this medication is mood effects. And there's a significant subset of patients who have problems with depression, irritability, and sometimes even psychotic depression on this agent. So you have to treat, it's not an easy, safe drug. You have to pay attention to how people feel on it and how they react to it. But nonetheless, it's here to stay. I mean, it's used all the time. And now most of the patients I see, their first drug they've been started on is levetiracetam. And every month I see one or two patients in the clinic that come to me because they can't tolerate the levetiracetam and they want me to take them off of it. Either because it was started too quickly, or they're too sleepy, or because of side effects on mood. Pregabalin is a very effective drug, and it's similar to levetiracetam in some ways because it has no drug interactions. It's a very safe medication. This would be a wonderful drug, except it causes weight gain. And it can cause very significant weight gain, which is a real problem for many patients. It's also, levetiracetam is a broad spectrum drug. Pregabalin is only useful for focal epilepsy. It can make generalized epilepsy worse.
John, levetiracetam, the side effect profile, can it be adjusted if a patient came to you well controlled with this drug but complaining of a little bit of darkening of mood? Could you say, well, I think we could try the dose a little lower?
Right. Exactly.
So it isn't just you either have it or you don't have it.
It depends on the degree of the problem and the dose they're on. But yes, you can lower the dose, they can help. You can use antidepressants, SSRIs, often help. So you can get by with this in many patients, but there are some patients that just can't tolerate it at any dose. Lacosamide is a medication that's been around for 5 years. It's a very useful drug. It's approved for focal epilepsy. It appears to be quite safe. It causes some alteration in the EKG, but that doesn't seem to be of clinical significance. It can be given IV. There's an IV formulation. The biggest problem with the medication is there's no generic form, so it's really expensive. But it's quite effective for focal epilepsy. We're using it occasionally to treat people with primary generalized epilepsy with generalized tonic-clonic seizures. It seems to be helpful for those patients. Unclear what it does for smaller seizures. Rufinamide is a new medication that's used primarily for Lennox-Gastaut syndrome. We really haven't found it useful for anything else. So maybe Rusty can give a talk about that later. Then there's new drugs. Phil told me he came today because he wanted to hear about new drugs. So here's my slide about new drugs. There's two new drugs. Azogabine, sold as Potiga, is now on the market. It was approved last year, and it's been in the pharmacies for about 2 or 3 weeks, or some pharmacies for 2 or 3 weeks. Some pharmacies are still ordering it, but it's now released. This is approved for adjunctive treatment for adult focal epilepsy. It has a unique mechanism working as a neuronal potassium channel opener. There's no other anti-epilepsy medication has that mechanism. What that will mean in terms of clinical efficacy is not yet clear. Adverse effects, I don't really have a feeling yet for the adverse effects of this agent because I'm not sure that in my patients have actually started to take it yet. I prescribed quite a few on it, but there's just still a process of getting the medication and starting it. But what was concerned in the clinical trial that there is an incidence of people with psychiatric symptoms on this and also urinary retention. Those are the things I'm going to be look out for as special concerns with this agent. Typical adult dose is somewhere around 450 to 900 milligrams a day. It's recommended 3 times a day dosing. The other thing about this is that in animal studies, it was effective in every animal model it was tested against, so there's at least some hope it might be broad spectrum, but that's not demonstrated yet. And then clobazam is an old medication. It's been in Europe and Canada for decades and was released in the U.S. for treatment of the Lennox-Gastaut syndrome. I haven't used it. It seems to me like an expensive benzodiazepine, and I'm not sure what I would use it for.
But it has a lot less sedation than other alternatives for maintenance benzodiazepines.
Less than clonazepam?
Yeah.
Okay. Well, there you go. I haven't ever used it. So we're running out of time, so I'm not going to talk about this. I want to at least talk about this before I close. This is my cheat sheet. So if there's one sheet that you want to remember, this is it. This is what I actually do when I'm in clinic and trying to manage these patients. Is I pick drugs based on this sheet. So the first thing you want to do is determine if somebody has focal or generalized seizures, and that will allow you to choose your best agent. So there's a list for each of these drugs. You know, drugs like phenytoin are not good choices for generalized epilepsy. Valproate, topiramate, levetiracetam, zonisamide, and lamotrigine is sort of your roster of drugs that we commonly use to treat generalized epilepsy. Because some of the other drugs on the other list make generalized epilepsy worse. It may exacerbate myoclonus, things like that. The real key is the second part here. Choose by tolerability, safety, kinetics, and comorbidity. Because when you're seeing these patients with difficult to control epilepsy clinic, the honest truth is you don't know which drug is going to work, or if any of them are going to work. And you can come up with a list of 5 or 6 drugs that are worth trying and have a chance of efficacy. So you choose among those 5 or 6 drugs based on their other properties, particularly their side effects. And so if you want a drug that's most tolerable in terms of mood and cognition, you would pick lamotrigine. If you have a non-compliant patient, you want a long half-life, you pick zonisamide. If you're lazy and you want something that's easy for you, then you would pick levetiracetam or pregabalin, which don't have drug interactions and are very easy and straightforward to start. If somebody's overweight, you might try topiramate or zonisamide. If somebody has migraine, you might pick topiramate or valproate. If you have somebody that you're really worried about having seizures and you want to get them protected as quickly as you possibly can, you pick something that works quickly, and that includes phenytoin if you load it. Levetiracetam appears to be effective at even low doses, as does topiramate, pregabalin, and glucosamide. So those are agents you might pick, whereas drugs like lamotrigine can take a couple months to get to an effective dose. Then if you want to give IV drugs, there's a list of drugs that you use IV, especially phenytoin, phenobarbital, valproate, levetiracetam, and glucosamide. And then there's a list of drugs to avoid. Phenobarbital for chronic use, valproate in women of childbearing age, tiagabine because it doesn't work, gabapentin because it doesn't work, oxcarbazepine in older patients because of hypernatremia, palmate because of safety issues.
In terms of effectiveness of the drugs for early efficacy, we usually use phenytoin or Keppra. Are there others? Has there been any comparison between others and those two?
There have been studies. The trouble is doing a meaningful study to compare efficacy. It's extremely difficult to compare efficacy because of heterogeneity of the patient population, because of picking the right dose, between doing a really adequate control study. So there are some studies comparing efficacy, but in general, they're not conclusive.
One drug or two,
One drug, I already said that.
until
And-
then the patient still has seizures. Then what?
Next slide.
Oh, I thought you were.
Well, I'm running out of time. We're going into the snack break. The first drug doesn't work. It doesn't stop the seizures. Give schedule to cross over to a second drug, ideally monotherapy, where you're tapering the first drug and adding the second drug. There's little evidence that trying multiple drugs, having somebody on 3 or 4 drugs, increases efficacy. Sometimes patients get stuck on that, but that's really that increases adverse effects, and there's little evidence that increases efficacy. If 2 or 3 appropriate agents are not effective, the patients probably should be monitored to understand their syndrome and what's going on and why they're not responding. And epilepsy surgery should be another talk. So, thank you. For questions from Harborview. There are no questions.
So we'll take a very short break.
Thank you.
Yeah.